Bismillah ar-Rahman ar-Rahim. Good afternoon, everybody. I will start our press session. The first presentation by Professor Martin Picard. Martin Picard is a medical oncology in Brussels, Belgium. Her primary interest in breast cancer and drug development. She is the principal investigator in many clinical trials, including the HERA trial, MENDAC trial, and ALTO. She is also the co-founder of the Breast International Group. She is also the vice president of the ESMO between 2012 and 2013. Her presentation is, unfortunately, she is recorded about the anti-HER2 therapy, advances, and current challenge in the early disease setting.
Dear colleagues, it's a great honor for me to be asked to review with you today the advances, but also the challenges that we face in the treatment of early HER2-positive breast cancer. Here are my conflicts of interest. So, as you are all aware, we have seen the development of several powerful drugs targeting the HER2 receptor in the last 15 years. And what you can see on this slide are the 4 targeted drugs that have reached the adjuvant setting. We have 2 anti-HER2 monoclonal antibodies, trastuzumab, the parent drug, that binds to domain 4 of the extracellular portion of the HER2 receptor, then pertuzumab, the second anti-HER2 monoclonal antibody, which binds to domain 2, the dimerization domain of the HER2 receptor. Then we have an antibody drug conjugate, first in class also, TDM1, which represents a binding of the HER2 and monoclonal antibody with a very powerful cytotoxic agent through a non-cleavable linker. And finally, we have the class of the small molecule tyrosine kinase inhibitors, among which the drug that has reached the early disease setting is neratinib. And with these drugs, we have seen essentially 3 strategies being developed in sequence. The very first one consisted in single HER2 blockade using trastuzumab. The second strategy was the exploration of dual HER2 blockade using either the 2 anti-HER2 monoclonal antibodies or the combination of trastuzumab with a small molecule tyrosine kinase inhibitor. And the third strategy has been the introduction of TDM1 in the post-neoadjuvant setting, a strategy that I'm referring to as the Trojan horse. So in this presentation, I will very briefly summarize what we have achieved so far, but then discuss with you the unmet clinical needs that we continue to see in our daily clinical practice, and we will see which are some new opportunities for an improved management of our patients in the coming years. Well, very, very quickly, trastuzumab, of course, is a life-saving drug. And from this recent meta-analysis performed by the Oxford group, we know that this drug has a long-term impact on overall survival of women with early HER2-positive breast cancer. This meta-analysis combined the data of 7 trials involving over 13,000 women with a median follow-up of slightly over 10 years. And what you can see here is that adding trastuzumab to standard chemotherapy in comparison with chemotherapy alone reduces the risk of recurrence. This translates into a 9% benefit at 10 years. There is also a reduction in local recurrence, which is more modest. The main impact, as you can see, is on distant recurrences with an absolute reduction of 6.2% at 10 years. And very importantly, there is a demonstration that trastuzumab reduces breast cancer mortality by an absolute 6.4% at 10 years. This meta-analysis shows that non-breast cancer mortality is unchanged, and it also shows that all subgroups benefit similarly, according to age, nodal status, grade histology, or HER2 CEP17 ratio. The next step was then the exploration of dual HER2 blockade. And here we have two strategies that have been FDA and EMA approved. One is the use of trastuzumab and pertuzumab in combination with chemotherapy. And the second one is the sequential administration of 1 year of trastuzumab and then 1 year of neratinib. And of course, this is the result of the conduct of very large adjuvant trials. There were, in fact, 3 such trials. ALTO, which explored the combination or the sequential use of trastuzumab and lapatinib. EXTENET, which explored the sequence of trastuzumab and then neratinib. And AFFINITY, which explored the use of the 2 anti-HER2 monoclonal antibodies compared to just trastuzumab in combination with chemotherapy. Essentially, what this slide shows you is that all these strategies work. Even the combination of trastuzumab and lapatinib reduces the risk of a disease-free survival event. And the reason that ALTO failed has to do only with the statistical plan. But in fact, what we can say is that there is a benefit from using dual HER2 blockade. However, we have to recognize that the magnitude of this benefit has been more modest than we had been hoping for. For example, you can see that in the AFFINITY trial, the benefit is exclusively seen in node-positive patients, and it's a benefit of 4.5% in invasive disease-free survival. Similarly, in EXTENET, it was also very clear that the benefit of the sequencing of trastuzumab and neratinib was mostly evident in the very high-risk patients with 4 or more positive nodes. And interestingly, also more evident when the tumor was expressing hormone receptors. This is just to show you the results of the AFFINITY trial at a median follow-up of 74 months, with overall, as you can see, modest benefits between chemotherapy and trastuzumab or chemotherapy plus trastuzumab and pertuzumab. And this benefit, as I explained to you, was not at all seen in node-negative disease, in part perhaps because the prognosis of these women in the control arm was absolutely outstanding, with a 95% invasive disease-free survival rate at 6 years. Very difficult, of course, to improve upon such a great result. And then, of course, the third strategy corresponds to the introduction of T-DM1 as a salvage therapy for women who present residual invasive disease after neoadjuvant systemic treatment using chemotherapy and anti-HER2 therapy. And this is, of course, based on the very famous CATRIN study, which, as you can see, randomized over 1,400 women with residual disease at surgery between trastuzumab or T-DM1. And clearly, T-DM1 was superior. It reduced the risk of an invasive disease-free survival event by 50%, which translated into an absolute IDFS gain at 3 years of 11%. And we are still waiting now for the overall survival results of this landmark clinical trial. Now, having achieved these excellent results, the next question has been to see whether we really need to treat aggressively all our patients, or whether there is not a subgroup of patients which is clearly overtreated by the use of aggressive chemotherapy with anti-HER2 therapy. And the first attempt at treatment de-escalation has been to get rid of anthracyclines, which has been achieved successfully in the adjuvant setting thanks to a trial conducted at the Dana-Farber that we will review in a minute. The other de-escalation attempt has been to try to reduce the duration of trastuzumab. This duration had been fixed arbitrarily at 12 months. And some investigators very rightly have started to think that perhaps 6 months of trastuzumab, or sometimes even 3 months, would be good enough. The answer for today's clinical practice is indicated on the slide. So the regimen of adjuvant paclitaxel with trastuzumab, omitting anthracyclines, is recognized as a standard of care for small T1N0 tumors. And my view for the de-escalation of the duration of trastuzumab is that this is probably a reasonable thing to do for women with a relatively small tumor burden, T1, T2, and 0, hormone receptor positive, and older women. And I will explain to you why in a minute. So here are the very interesting results of this single-arm de-escalation trial, the APT trial conducted in the Boston region. So more than 400 women were enrolled in this trial. They received paclitaxel for 12 weeks and trastuzumab for 1 year, but there was, of course, a selection of patients. They had to present with relatively small tumors and 0 or only with microscopic involvement of the nodes. And 2/3 of this population had also positive hormone receptors, as you can see. At 7 years, the results were very good. There were only 7% relapses, but among those, only 4 cases of distant relapses. Here you see a slide summarizing the attempt at decreasing the duration of adjuvant trastuzumab. And here, as you know, we have one large positive trial, the UK Persephone study, but we also have negative trials, including a very large French trial, the PHARE study. Why were these trials negative trials, and why was Persephone a positive trial? Well, this has to do with the pre-specified non-inferiority margin, because these trials were non-inferiority studies, which is always very difficult in oncology. And you have to determine a priori what is going to be your the upper margin of the 95% confidence interval that you will accept to declare that the treatments are equivalent. And as you can see, for the first 2 studies, the upper limit of the 95% confidence around the hazard ratio was higher than what had been pre-specified in the statistical plan. However, in the Persephone study, this was not the case. The upper limit was at 1.24, and the pre-specified non-inferiority margin was set at 1.29. So this trial, in fact, succeeded in demonstrating non-inferiority of 6 months or compared to 12 months. The problem I have with these trials is that they took a long time to recruit, up to 8 years. During this time period, the standard of care changed. So the problem is that in these trials, a small proportion of women received concomitant trastuzumab and chemo, and many women received trastuzumab in sequence with chemo, and we know that this is an inferior strategy today. And you can also see that there was, of course, a selection of patients based on the percentage of node-negative women, more than 50%, close to 60% in the large trials. Another worry that I have is that in the Persephone study, when you look at the forest plot, it looks that 12 months is still superior for certain subgroups of patients, and particularly patients receiving concurrent trastuzumab with chemo, which is what we do today in virtually all the patients we treat. Now, here is a trial I wanted to mention to you because it's a courageous study that has started in the United Kingdom and that will be of interest to many regions of the world. It's a trial in which patients will receive a neoadjuvant regimen consisting in a taxane plus dual HER2 blockade. But as you can see, if a pathological complete response is documented at surgery, the patients will stop treatment. They will not continue receiving anti-HER2 agents like what we are doing today. And that's an important question that indeed needs to be addressed. Okay, now, what are the unmet clinical needs and the new opportunities? I think that low volume disease patients are probably overtreated with today's standards of care consistent in taxane and tetracycline anti-HER2 agents. The second challenge is that high volume disease patients, as I will show you in a minute, continue to have a suboptimal outcome. And finally, occurrence of brain metastases has remained unaffected over this 15-year period, during which we have been improving our adjuvant or neoadjuvant systemic therapies. So clearly, we have patients who are overtreated, and so we need to design clever de-escalation trials with a lot of caution, because these patients have a chance to be cured and we cannot put them at a very high risk. And this is why the de-escalation trials are neoadjuvant trials. The big advantage being that if there is a poor result at surgery, with your de-escalation regimen, you can still escalate therapy after surgery. So these trials are considered much safer than adjuvant de-escalation trials. And you see that the very first effort is to identify patients who can omit anthracyclines. There was an elegant small neoadjuvant trial conducted by our Dutch colleagues, TRAIN2, comparing 9 cycles of paclitaxel carbo to 3 cycles of FEC followed by 6 cycles of paclitaxel carbo. The results were extremely encouraging with similar pathological complete response rates, similar 3-year event-free survival rates, but what you have to examine is the 95% confidence interval around these figures, and you will immediately understand that there is still uncertainty and that this trial is too small to change practice. This is why there are 2 much larger de-escalation trials running at the present time, COMPASS in the United States and Decrescendo in the Breast International Group network. The philosophy is the same. These are large single-arm de-escalation trials. There is no randomization, but there is a requirement to observe very good results at 3-4 years median follow-up. In the United States, they take patients even with T3 lesions, even with clinically node-positive disease, hormone receptor positive or negative. In the big trial, we are a little bit more cautious. We are not allowing patients with large tumors or clinically positive nodes to enter the de-escalation study. And we also focus on hormone receptor negative disease. But in the 2 trials, essentially the neoadjuvant treatment is the same, a taxane, plus dual HER2 blockade with trastuzumab and pertuzumab, 4 cycles. If the patient has a PCR, no anthracycline is given. You continue with the same anti-HER2 treatment. And of course, you need to see these very good results at 3 years. There have been other interesting attempts at treatment de-escalation, but again, they will not change clinical practice because the trials, I'm afraid, are too small and there are too many uncertainties still. But I wanted to mention this elegant study initiated by our Spanish colleague, Forgain. This is a trial where molecular imaging is used to identify a group of truly HER2 addicted tumors, tumors which are going to respond beautifully to anti-HER2 targeted drugs and which might not need chemo. As you can see in this trial, patients had a PET scan done at baseline, and this PET scan was repeated after 6 weeks, so 2 cycles of HP, trastuzumab and pertuzumab, in the investigational arm. There was also a control arm where chemotherapy was also given. And what was interesting there is that if there was a good response on FDG PET, so a reduction in the SUV max by 40% or more, patients could continue with the chemotherapy-free regimen, the 2 anti-HER2 monoclonal antibodies alone, and they reported a very interesting pathological complete response rate, very close to 40% in this de-escalation arm. Now they are waiting, of course, for the 3-year event-free survival results. So this is clearly a study that needs to be followed. And then there is another initiative conducted by the International Breast Cancer Study Group for triple positive breast cancer. So these patients receive a neoadjuvant regimen, which is pretty standard, paclitaxel, trastuzumab, and pertuzumab. And this is compared to an investigational arm of endocrine treatment, letrozole, with dual HER2 blockade, trastuzumab and pertuzumab, and the addition of a CDK4/6 inhibitor, in this case, palbociclib. I told you, high volume disease patients continue to have a poor outcome. So patients presenting with big tumors, clinically positive nodes. And this can be seen in the affinity trial from this elegant step analysis conducted by our statisticians. So this statistical method explores the treatment effect for overlapping patient subgroups defined by a continuous covariate of interest. So in fact, what you see here in the vertical axis is the 6-year IDFS rate, and along the horizontal axis, a clinical composite risk score that integrates number of positive nodes, tumor size, age, and hormone receptor status. And what you can see is that patients with node positive disease are still, in spite of dual HER2 blockade, are still experiencing an IDFS rate at 6 years that is below 80%. It is 79.4% when you get pertuzumab. It is 75.4% when you get trastuzumab alone. So clearly indicating that in these patients, we should be able to do further progress. And what are we going to explore for these patients? Well, for the triple positive disease patients, there is clearly an interest in exploring the addition of a CDK4/6 inhibitor to endocrine therapy once you have completed the administration of chemotherapy and dual HER2 blockade. And another interesting venue of future research is, of course, to try to boost the immune system. And why is that? Well, in the affinity trial, in our translational research efforts, we could demonstrate that the outcome, the benefit of pertuzumab was much larger in the presence of a high TIL count. So when you could demonstrate more than 75% of TILs in the tumor, you had a much bigger benefit from pertuzumab compared to patients with lower TIL levels, suggesting that there is perhaps some improvement that could be expected with immune checkpoint inhibitors. And this is actively now pursued, at least by some companies. And this is just an example of a strategy under exploration. So it's neoadjuvant treatment with chemotherapy, dual HER2 blockade, and atezolizumab versus chemotherapy, dual HER2 blockade, and a placebo. One of these trials, Impassion 50, has already reported the pathological complete response results, which were a little disappointing. There was no improvement in PCR, but we are still waiting for event-free survival. And another trial, with much larger, is in fact powered to look at event-free survival. Also, TDM1, as we just so is clearly an important drug for the salvage of patients with residual disease after neoadjuvant systemic treatment. But here also, for some patients, we should be able to do better. What you can see here are in the purple columns is the outcome of the women who got TDM1 as salvage therapy in terms of 3-year event-free survival rate. And what you can see is that if the patients presented with bulky tumors, inoperable tumors, or if they presented with clinically positive nodes and they were also hormone receptor negative, their outcome was still suboptimal because they didn't reach an 80% 3-year event-free rate. They were below 80%. And this explains why important trials like the one on this slide are currently recruiting patients, and this one is very advanced, I think. So it will compare TDM1 to DM1 plus atezolizumab for women with residual disease after neoadjuvant systemic treatment. And this is another trial, very interesting, that will challenge TDM1 with this new, very powerful antibody drug conjugate, trastuzumab deruxtecan, that has already been shown to be better than TDM1 in metastatic HER2-positive breast cancer. And finally, very briefly, a disappointing observation. The occurrence of brain metastasis has remained unaffected, in spite of all these new interesting targeted drugs that we have been introducing in the treatment of early HER2-positive breast cancer. Indeed, if you look at all the adjuvant trastuzumab trials, the ALTO trial, the Affinity trial, the Catherine trial, there has been no impact seen on the emergence of CNS metastasis as first site of metastatic disease. And this is, of course, disappointing. Are we going finally to see an improvement in the coming years? And I think the answer could well be yes. And this is because recently we heard some interesting results about intracranial responses with some of our new targeted drugs. Pertuzumab and trastuzumab, well, the only thing that we could see in the Cleopatra metastatic trial was that the dual HER2 blockade did not decrease the emergence of bone mets, but delayed their development. In contrast with the drug neratinib, there is an indication that there could be a real shrinkage of brain metastasis with this drug, and a diminished incidence of brain metastasis has been seen in phase 3 trials conducted in advanced disease. Tucatinib, even more interesting, the small tyrosine kinase inhibitor, very specific for inhibition of the HER2 tyrosine kinase, has been nicely demonstrated to impact favorably patients who present with CNS metastasis. In the HER2 CLAM trial, the benefit of the addition of tucatinib to a regimen of capecitabine and trastuzumab was seen overall, but was also seen for patients presenting with CNS, even active CNS disease. And finally, more recently, we have also heard that trastuzumab deruxtecan is active against brain metastasis. This was seen in DESTINY-03 with a response rate in the CNS of 63%, much higher than the one seen with TDM1. And the COMPASS trial for patients who will not have a pathological complete response will compare two regimens, TDM1 or TDM1 plus tucatinib, as a post-neoadjuvant therapy, and hopefully we will see a decrease in the emergence of CNS disease in the coming years with such a regimen. So to conclude, this is what we do today. So in patients presenting with small tumors clinically non-negative, we ask our surgeons to go first, and then we offer paclitaxel in combination with 1 year of trastuzumab. we add endocrine treatment if the tumor is expressing hormone receptors. For the larger tumors, you know that today the recommendation is to go for neoadjuvant systemic treatment. And there, if you are lucky and if pertuzumab is reimbursed in your country, you can, of course, use chemotherapy with dual HER2 blockade. In case of a pathological complete response, you will continue with the anti-HER2 drugs alone. You will add endocrine treatment if the tumor expresses hormone receptors. If there is residual disease, you will switch to TDM1 and add endocrine therapy if indicated. Now, this treatment algorithm could change in the near future. So, for the small tumors, there is currently a trial in follow-up by the Dana-Farber comparing paclitaxel trastuzumab to TDM1. So it's possible that TDM1 will replace paclitaxel and trastuzumab. For the patients with small hormone receptor positive tumors, maybe we will see the development of regimens of endocrine treatment, trastuzumab, and CDK4/6 inhibitors. Then for the patients presenting with larger tumor burden, we will probably continue, of course, to start them on neoadjuvant systemic treatment with chemotherapy and dual HER2 blockade. But what we could perhaps see in the future is the use of taxanes only if the trials Decrescendo and Compass are positive trials. And what is also something that we could expect in the future is the replacement of chemotherapy by an antibody drug conjugate. But of course, these trials still need to be conducted. And then for women with residual disease after neoadjuvant systemic treatment, it is possible that we will see new standards of care in the future, such as TDM1 plus atezolizumab or TDM1 plus tucatinib, or of course, trastuzumab deruxtecan. I hope I could overview this fascinating topic without forgetting too many things. And I also sincerely hope that we will see a better tailoring of the treatments of our patients in the near future. Thank you very much for your attention.